closing position. When they open, they get a click. In opening, now their alignment is fine. And when they close, they drop off again. With no reduction, the disc is anterior. They open, the disc is anterior. They close, the disc is anterior. The disc is anterior throughout the whole range. Okay? And they ultimately have a limitation in opening with a springy end feel because they're jamming into the disc.
Would you say it's because of muscle imbalance that they're having that?
May or may not. Chances are there is a muscle imbalance. However, in order to get this, you need some sort of structural change. So there's been some deterioration in the joint itself, or remember I said the ligament in the back is elastic, so if you lose the elasticity of the ligament, it doesn't recoil. Potentially you could have hyperactivity of the lateral pterygoid that keeps that disc living forward and throws off the muscle imbalance. So maybe you can help clean this up. But usually this is a TMJ that's gone through some stuff. This is a dislocated jaw, and it can get stuck there, or they can actually dislocate and self-reduce. But this is where it jumps the joint line. So the condyle is in front of the eminence. Okay, so that's what I said is different than an anterior displaced disc. It's different than a subluxation or dislocation. Subluxation is a partial almost, like what you just saw me do. And then dislocation is when it goes all the way. Okay. You can lock jaw without necessarily being dislocated because you can have a different kind of disc displacement. So it doesn't automatically mean lock jaw. But a lot of times if they dislocate anteriorly, they are locked. They're locked over.
The MRI can confirm for both on the last slide?
No, because an MRI is still. So the MRI will look the same for both of these guys. If they happen to do fluoroscopy, then they can see if they reduce, maybe. But the click will let you know, the palpation will let you know a little bit, potentially let you know if they reduce it. Also, if they do a close and an open, so if they do two stills and they do a close and an open, they can see if it reduces. So I don't know if they do that regularly. Do you know if they do that regularly, an open and a close? Anyone? No. We all don't know. Obviously, all of us treat TMJ a lot. So if they have scans, then you just take a look at the scan. And if they happen to have a closed and an open scan, then you can tell if they're reducing. The curves, the deviation, you can have a C curve or an S curve. And theoretically, it could be because of a jammed joint, so their jaw just swings to one side because both joints aren't moving. Or if they have some deterioration, their pathway is altered. So they have an altered, they got, like you saw, mine was kind of an S, kind of shoots over. So it's maybe avoiding a hitchy spot. So, as far as what you would do, we spoke about how you would treat them. Muscle motor control wise, it looks like this. This is a big treatment, so you can treat this. You can treat them with rest, ice modalities, especially if they're inflamed, generally do elevation, but you teach them how to minimize their motion, calm it down. And then the Rod8 6x6 exercise is very common. The reason for his 6x6 exercise is you're trying to teach them how to relax their jaw. So you teach people how to relax their jaw, and then you can teach them how to try and balance out the firing of the muscles of the jaw. So strengthening, maybe, motor control, probably. Right? So their 6x6 exercise, if they tend to be clenchers, you rest the tongue on the roof of the mouth and you let the teeth separate. And you breathe, you just do that to try and teach them to stop clenching. You put a cork in the mouth and they have to hold the cork and then talk. And then trying to be able to use their muscles without gripping down. So teach them to create a little bit of space. The rhythmic stabilization, you open up a little bit, and you do hold, 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 hold. You can even do diagonals. So that's how you try to change the firing of the muscles of the jaw. And that starts to balance things out. So whether it's strength or motor control, you can just discuss that. Definitely in Rod8 has that you want to stretch the back of the neck, because chances are they're jammed here. So you do a self-stretch of deflection, you do your elongation, which is the next one. Right? So maybe it's retraction, but it's really lower neck extension, upper neck flexion to elongate. You're changing their posture. And then you want to teach them how to do retraction of the shoulder girdle. So usually your program is going to take them into scapular stabilization, probably cervical stabilization. And you can treat the muscles. These are kind of the ways to do it. So be aware that there's such a thing as an anterior disc displacement, and it can be with reduction or without reduction. And if it's with reduction, That's where you can copy it. Okay. That's a big hint if anyone's listening. Alright. So, I'll be here Thursday from 10 to 12. So we'll do techniques, and then more techniques. Check your hands. And your manipulation, your test for manipulation is a straight extension manip, but on Thursday, if you want to look at how to do a quadrant manip in the thorax, we can definitely do that. There's just a subtle little change. That's that. C3 transitive process is found halfway between the mastoid process and the angle of the mandible. That's false, because what's found there? C1. Question 2?
Yes,
Right. Question 3. Which of the following statements is true with regards to the cervical or CV examination? D. The gross loss of cervical rotation associated with cervical splitting may indicate a dense fracture. Why is it not the other one? Good. I like it, speaking code, you guys know what I'm talking about. So what I was asking was, in B, I said a unilateral loss of left rotation that demonstrates a greater loss with CV and extension would most likely point to the left joint, OA joint. Why would it not point to the left OA joint? Because the anterior glide of the right OA joint. That's the combined movement. Okay? Know your combined movements for OA. With a base and supine, flexing the C4-5 segment, then translating C4-5 segment to the right will induce a side bending at C4-5 that will assess which? Allow assessment of right upslide. So you brought them into flexion, so you're interested in upslide. You brought them into left side bending, which means you're biasing the right upslide.
Yeah, this is
Okay?
I think I have 100. So.
During the combined movement and seated pivum, it was determined that a patient presents with limited side flexion left, which was worse, more limited, inflection left side bending. Which of the following hypotheses is correct for this finding? The left facet of C5 may, wait. Yeah, you're right. I got one wrong. The right facet of C4-5 may present with a limited upslide with the paddle assessment because they're flexion on the left side. When discussing joint mobilization in the cervical region, a joint mobilization technique for C4-5 in the posterior right quadrant would best be treated with a downslide mobilization of right C4 on C5 facet. D. Throughout the subjective and scan, there are certain findings that will tend to lead the PT towards the cervical or CV region, craniovertebral region. Which of the following will most likely lead a therapist to further assess the craniovertebral region? Occiput the C2 first. C. The patient presents with unilateral loss of rotation greater than 50% of range of motion with history. Cervical disc pathologies or herniations are D. Are often a part of a degenerative cascade and oftentimes from subtle wear and tear.
I think I'm having 90. I just